My name is Carolyn Carey. I'm a pediatric neurosurgeon, and I'm going to speak on hydrocephalus. I'm going to talk about diagnosis and treatment so that we can understand that a bit more. In looking at hydrocephalus, I'm going to go over some general information about it. I'm going to talk about the types of hydrocephalus, some clinical issues we deal with before surgery, some surgical techniques that we use, and a long-term picture for children affected with this condition. In looking at the history of hydrocephalus, it's been around for quite a long time. Hippocrates described it, as well as some Arabian physicians, and Galen early in history. They thought that it was a buildup of cerebral fluid, and in the 10th century they actually had an external drainage system that they used, and in 1774 they started using ventricular punctures. Ventricular puncture means that we would put a needle into the fluid pockets in the brain where the spinal fluid is contained. And I'll show you some imaging of that later on so that we can understand that better. In 1881, Wernicke initiated some subdural ventricular taps and external drainage systems to try to treat this condition, but we really didn't have any adequate treatment until about the 20th century. Children who are afflicted with this condition can have very large heads if left untreated. Before we had a good system for shunting and treating this condition, children would have breakdown of their skin, their bodies would be quite tiny, their heads would be quite large, and they usually would die from this condition. Now, children can be treated and can live normal lives, and this little guy here is an example of that. The incidence of hydrocephalus has decreased when they looked from 1985 to 1990 and compared that to a study done from 2000 to 2005. It had decreased about 8.8%. And they felt this was due to a decrease in congenital malformations, possibly some termination of pregnancies, and also a decrease in head injury. But post-hemorrhagic hydrocephalus, which is a condition which occurs in premature infants, has remained stable. And I'll talk about that a little more as we go on as well. The incidence of hydrocephalus is anywhere from 1 in 500 to 0.8 per thousand live births. There's an increased recognition of this now. And in 1995, there were about 36,000 initial shunts placed and 14,000 revisions done. That number has changed some now because we are doing a procedure where we try to open the system a bit and not shunt the system. And again, I will show you some examples of that later on. The cost for these shunt placements and revisions was more than $100 million. And shunt infections also cost the healthcare community up in the billion-dollar range now. There are different types of hydrocephalus. One type is obstructive, and what that means is the pathways that normally allow the fluid to flow around the brain, around the spinal cord, and then get reabsorbed, get blocked or obstructed, sometimes by tumor, sometimes by blood or hemorrhage, and sometimes by just an abnormality in the brain tissue itself, such as aqueductal stenosis. There's also communicating hydrocephalus where the fluid can circulate but isn't able to be absorbed well. We see this sometimes in infection, we can see it in trauma, and in the premature babies with the post-hemorrhagic hydrocephalus, we can see it in that condition as well. You can also have hemorrhagic hydrocephalus or blood within the ventricular system from vascular malformations, from tumors bleeding, and from trauma as well. The hydrocephalus can be congenital, which means you're born with it, or it can be acquired from infection, trauma, tumors, blood in the ventricles, many different reasons. When we look at CSF dynamics, and CSF stands for cerebrospinal fluid, we know that this is produced in the choroid plexus, and this process requires energy. About 20% of our cardiac output enters the brain and goes through the tinier blood vessels in the brain. And it's responsible for our blood flow autoregulation, and it provides oxygen and nutrition to the brain. Because the CNS metabolism 20 to 50% of CSF is produced and travels through the white matter and tissue of the brain and into the ventricle. This is an image showing the ventricular system. This is the lateral ventricle. It's like a C, and there's a lateral ventricle on the right side and on the left side. This ventricle in the middle is the third ventricle. There's one third ventricle, and the two lateral ventricles drain into this third ventricle. And then the third ventricle goes through this little tiny line, which is the aqueduct I mentioned before, into this fourth ventricle. And then from the fourth ventricle, it goes out around the brain, around the spinal cord, and gets absorbed into the surface of the brain in this area and back into our bloodstream. This is a different diagram, just again showing the ventricular system. So you can see the two lateral ventricles in this picture. You can see the third ventricle, the aqueduct going into the fourth ventricle, and again the fluid going out. Within the ventricular system, there are some blood vessels. They're called choroid plexus or choroid plexi, and they're in each lateral ventricle, and they loop around into the third, and they're also in the fourth. It's also in the fourth ventricle as well. And when you look at cerebrospinal fluid, about 25% sits in the ventricular system. It turns over about 3 to 4 times a day. We make 0.35 milliliters per kilogram per hour in children. And in adults, that's about 400 to 600 cc's per day. In children, depending on their size, that varies. It can be anywhere from less than 100 to 300, 400 cc's, which is quite a lot of fluid to be produced, circulate, and be reabsorbed into your bloodstream. Some children in third world countries don't have good access to treatment. Again, their heads can get very large. This downward gaze is called sunsetting, and we see that in children when their shunts are not working well or when they have severe hydrocephalus and they're not shunted. And we're working to help the children in these third world countries by going there, and some of our pediatric neurosurgeons are working in those countries. We do mission trips to the different countries and try to help the children either by acquiring shunts and helping them in that way, or by doing what we call a third ventriculostomy, which is opening up some pathways again to try to allow the fluid to get through and be reabsorbed. And we also try to remove some of the choroid plexus, which is the blood vessel, as I mentioned before, where some of the spinal fluid is produced. So there are some things we're doing to try to help children who don't have easy access to shunting procedures. If I look at the causes of hydrocephalus, it's usually a consequence of complex congenital anomalies, or intraventricular hemorrhage due to prematurity, obstruction due to tumors, trauma, or infection. Almost always it's due to obstruction or issues with absorption rather than overproduction of CSF. There is a type of tumor called a choroid plexus papilloma, and many people feel that there is some excess fluid produced when this tumor is present. But again, it comes down to reabsorption of the fluid, and that seems to be the major reason why children developed increased pressure and require some type of diversionary procedure to treat the increased spinal fluid pressure. This is an image, just to show obstruction. This is an image of a brain on a CAT scan with the ventricles being enlarged in this area. And you're going to see ventricles on some of these slides that are many different sizes. But in general, your ventricular system is quite small. And this is a little tumor or mass in that area called a colloid cyst. And it's blocking the pathway where the two lateral ventricles here have to drain into the third ventricle. So these ventricles are getting larger. The third ventricle is still quite small. By removing that lesion, you can open up the ventricular system, and they shouldn't need a shunt or need any further treatment. This again is a picture of hydrocephalus, and you can see where the fluid here is not being able to move into the ventricular system. So this is called transependymal fluid. And many people used to think, oh, the ventricles are under pressure, so it's pushing fluid out, when really the fluid just couldn't get into the ventricle because of the pressure within the ventricular system. Now, you'd look at this picture and say, wow, this kid definitely has hydrocephalus. But actually, this is a child who was a victim of non-accidental trauma or child abuse. And this brain now is turning cystic. So a lot of the brain is basically melting away. And so the fluid pockets are taking up that space and getting larger. But this child doesn't have hydrocephalus, but rather has cerebral atrophy due to trauma. This is an older person, and you can see there's very little brain tissue remaining. It's just a large fluid cavity and related to infection. So this can occur at any age. We take care of children and tend to see most of the problems that we deal with in children, but it can affect adults as well. There are other reasons to develop hydrocephalus. This is a serial imaging in a person who had a bleed in this area, and the blood went into the third ventricle and also caused some mass effect and prevented the fluid from flowing well, and so the ventricles are enlarging. There's also some blood here in the back of the ventricular system, and this person could be treated with a drain till the blood clears up and this clot resorbs to some degree. We can find out what the cause was for this, whether it's vascular or tumor, treat that, and they may not require shunting long term. This is another child with a tumor in the anterior portion of the brain. This is the brainstem and spinal cord. And again, this is causing an obstruction to the flow of the fluid through the lateral ventricles into the third ventricle. And so there's a buildup of fluid, and by treating this tumor, we may be able to open things up, but in general, a child like this usually needs a shunt to treat their hydrocephalus. This is a tumor in the fourth ventricle, or in the bottom part of the brain towards the back of the head. These are sinuses in the front of the head. This is the back of the head. Ears are out here. And so this mass is obstructing that little fourth ventricle, so the fluid again can't get out. So the ventricles up above get larger and require treatment. Now this type of picture, sometimes rather than shunting, we can do what's called a third ventriculostomy and open up the pathways a bit with a ventriculoscope to try and allow the fluid to bypass this obstruction. Again, another mass in this area that's just occluding the outflow, and the ventricles become quite large. So there are many reasons to develop hydrocephalus. I'm just showing some obstruction in this area. When we look at the symptoms of hydrocephalus, one of the main ones, of course, is headache, nausea, vomiting, papilledema, which means that they have pressure on the optic nerves. And this can be seen with an eye exam by dilating the eyes and looking in the back of the eyes to see if there's any pressure there. An altered level of consciousness. And as these increase, as you get headache, nausea, vomiting, and then have an altered level of consciousness, you know that you're getting sicker and more pressure, and you need to act more readily on children when they're deteriorating in this way. They can have brainstem symptoms with eye findings, respiratory problems, bradycardia or a low pulse, and they can actually die from their shunt not working well or from hydrocephalus not being treated. Some of the other symptoms that we see are developmental delay. Many times the children come in, their heads may be large, they may be having some symptoms of pressure, they may be behind in their development, and oftentimes once they're shunted and treated, they improve and progress very nicely. In older children, when their shunts aren't working well and they have increased pressure but aren't sick enough to warrant a visit to the doctor, but they're starting to get sick. But many families will say, well, they're just not doing as well as in school. They just don't seem to be themselves. And so that's an indication that they need to be looked at. We need to really check their shunt and see if it's working, or if they're not shunted, we need to see if they have any hydrocephalus that's affecting them. Visual loss is another thing that can occur, particularly when they have long-standing papilledema or pressure. When we look at timing, it's very important to keep in mind that if you suspect a shunt malfunction or increased intracranial pressure, it's very important that we know about that early or as soon as there's any suspicion that they may be having problems. We're always there, we're always wanting to be called and ready to be called. We'd much rather see a child and look at things and find out it's not the shunt or it's not a problem with hydrocephalus, rather than wait until they're so sick that we have to really make it an emergent issue. We sometimes measure intracranial pressure, and we always say, well, what do numbers mean? We may put a drain in someone and measure their pressure to see if they really need a shunt, or do they have hydrocephalus that needs treatment. And we know that a normal pressure may be somewhere between, say, 5 to 15, somewhere in that range, even as low as 1 or 2, as high as maybe 16, 17. But there's a range of numbers that we look at to look at normal pressures. But some children who have been shunted a long time may have a different norm. They might like their numbers very low or even a touch negative. So even though we do look for numbers, there's no one set of numbers that says, oh, you're perfect, there's nothing we need to do. It's something we really need to talk about, see how the child's doing, see how they respond to what we're doing to treat their symptoms, to drain them more or drain them less, to see where they're comfortable and where they like to have their pressure. As I said, we do that with ventricular drains. We can put in monitoring systems where we can put a little fiber optic cable into the brain tissue and monitor pressure to see how their pressures are doing. Sometimes children with shunts will have headaches and we don't really know whether their pressures are high or low. So we can do a monitoring run to see where their pressures lie and see where they're most comfortable. If we look at symptoms of hydrocephalus in infants, you look for progressive macrocephaly. That means their heads are getting bigger and growing at a rate that's too fast and jumping percentiles on the growth curve. They may have an anterior fontanelle, the little soft spot that becomes very tight. Their growth lines or sutures on their head may be splitting apart, and you have a space in between the bones on the head. They may have a downward gaze or sunsetting of their eyes. They may have some lid retraction, and they may have their eye findings may not be normal. A 6 nerve palsy means that they can't look laterally, and so we look for that sometimes too with increased intracranial pressure and hydrocephalus. In the myelomeningocele population, and that's children with spina bifida, where they have an open sac on their back, and their spinal cord is in that area, we close up their back, and when we do that, they often will require shunting. And once they have their shunt in place and their shunt stops working, they may turn up with suboccipital pain, which means pain in the back of your neck, or actually back pain. And that's something the children with spina bifida get that the other children who don't have spina bifida don't usually present with. They can have problems with their legs and arms because of the pressure in their head. They may have trouble with their bladder. They may have progressive scoliosis or curving of their spine. They may develop some fluid in their spinal cord, which is what a syrinx is called. But sometimes their ventricles don't change much. So if you have a child with spina bifida who has some symptoms going on and you get a picture and say, well, it's not really that different, you have to really think about their symptoms and put all that together to determine whether their shunt's working and investigate it further so that you can obtain an answer that's appropriate for that child. In looking at treatment, you have to think about why you're treating them, what's going on that makes you want to treat them for hydrocephalus or for shunt malfunction, when you should do it, is there a time that's better? If you have an infant with a big head and big ventricles, should you watch them a little bit, see if they really have hydrocephalus or just large ventricles? If their shunt's not working, should you watch them a little bit? Should you do a shunt study, or should you go ahead and just change their shunt? And then how to go about treating them. If we look at shunts, there are many variations on shunts, but in general, there's a proximal end to the shunt, a valve, and a distal end. I'll show a couple of different pictures here in a minute. So this is a ventricular catheter going into the ventricular system or fluid pockets in the head. It's very easy to see on a CT scan. An MRI scan, you can also see it. It's a little harder to see. These are barium impregnated catheters, which is why you can see them so well on a plain film or a CT scan. We have valves that have anti-siphon devices that try to keep the fluid from flowing out of the ventricles too readily. They may have a little pumping chamber, and they have a valve system. We have programmable valves now that can be adjusted to different levels so that we can allow more fluid to flow out of the fluid pockets or less fluid to flow out of the ventricular system. I think they're very useful, and you have to think about the children and what their needs are and whether they're the right candidate for programmable valve. We're using them fairly often, but some children do well with just a regular valve that doesn't need to be programmed. The programmable valves can be reprogrammed by the MRI machine, so whenever they have a scan, we need to make sure that their setting goes back to where it was. And there's just a small range of settings, but it can, as I said, it can go from letting a lot of spinal fluid out to less spinal fluid out. This is distal catheter, or the catheter that goes into the belly. And there are other areas where we can put a distal catheter. We tend to pick the abdominal cavity, but if that's not possible and we can't put it there, we sometimes put it into the superior vena cava and atrium of the heart. We sometimes put it into the pleural space around the lungs. We occasionally can put it into the gallbladder, but for the most part we try to put it in the abdominal cavity. When a shunt needs to be evaluated, you can look with a CT. We're trying to do less CTs now in general. We just had a new software upgrade and a new CT put in that has an extremely low dose of radiation. So we try to scan our children if they need a CT on that scanner. Rapid sequence MRI scan is another way to look at the ventricular system. It's a very quick scan. It might take 2 or 3 minutes. The children don't need to be sedated either for a CT or a rapid sequence MRI. Rapid sequence MRI has no radiation. We also do a fast MRI, which is a little bit longer than a rapid MRI. It takes about 15 minutes or so, but it gives you a 3D image of the brain and ventricular system. Also no radiation, and the children don't need to be sedated. A shunt series is x-rays of the head and chest and belly to look at the tubing to make sure it's connected and there's no disconnect in the tubing. We can do a shunt tap, or tap the little proximal end of the shunt system to see if the fluid is flowing. We can put in a little isotope and see if the isotope flows down to the belly by scanning them in a nuclear medicine study. And we can measure ICP when we tap the shunt. If we have a manometer and the fluid's flowing, we can determine what the pressure is. This is just an example of a shunt tap when we either do a nuclear medicine study or just tap the shunt to look for flow or to look for infection sometimes. So we clean everything off. We use a little tiny butterfly needle and tap the little upper portion of the shunt or the little tapping reservoir on the valve, and we can get fluid off from that area. The other way to treat hydrocephalus that really started probably, I remember doing in the late 80s, early 90s, where we were trying to use scopes to open membranes and open ventricular systems, and that's progressed so much in the last 25 years or so, however long that's been. And we really are able to go into the ventricular system now through the lateral ventricles into the third ventricle and try to open the membrane that sits just in front of the brainstem here and just on the floor of the third ventricle. By opening that membrane, the fluid's able to flow out through there, around the brain, and be reabsorbed. when you have an obstruction, such as a mass here or tumor here, or something that's preventing the flow through this area, and we open that third floor of the third ventricle, many times we have good success. When the children have had a bleed from prematurity, they have less success with that because they tend to have problems with absorption, not just with outlet obstruction. So it still works in some children. And when we decide about doing third ventriculostomies, you really have to look at the child, look at their pathology or what caused them to have hydrocephalus in the first place, what their ventricular system looks like now, whether it looks safe to open that area, and then make the decision as to whether that's a possibility. If it works, it's great. They don't have a shunt any longer. It eliminates the shunt. And we try to do that if that's a reasonable thing to do for a child. It works better in older children than it does in little tiny infants. They tend to have a better success rate. This again is just a picture of the floor of the third ventricle. This is the aqueduct that leads into that fourth ventricle in the back of the head. And this is the floor of the third ventricle that we try to open to allow the fluid to get out through that area. I kind of talked about that a little bit. I don't think we need to go through that. Shunt infection is something everybody worries about who does shunt surgery. If the children have a fever and have any belly pain or an elevated white count and they've had a recent shunt revision within the last several months, you always want to keep that in mind that it could be their shunt that's infected. Some children even who are out a couple years from their shunt surgery but have had a bladder infection or some other infection that could have gotten into their bloodstream, they could possibly have a shunt infection. So I have seen children that haven't had a shunt revision in quite some time show up with a shunt infection, but it's usually from another blood-borne organism from another system. You always want to look at the gram stain to see what the organism is. That's where they take the fluid and put it on a little slide and look at it to see what bacteria is present. Sometimes with a shunt infection you can have an abdominal pseudocyst, and what that means is you can have a collection of fluid that gets loculated in the abdominal cavity, and the shunt therefore won't drain well because it has nowhere to be absorbed or to move around. So it will back up basically and cause shunt problems, and you just have to externalize the shunt and get rid of the pseudocyst and replace the shunt either back in the belly or into another area. They may have ventriculomegaly with their shunt infection, and if they have a high fever, a high white count, redness around the shunt, they are signals that you need to really look for a shunt infection. Sometimes they can have a late infection that's kind of insidious. They may have a low-grade fever. They may not eat well. They just don't feel good. Their white count might not be particularly elevated, but if you suspect that, you really need to tap the shunt, send off the fluid, and check for it. Some of the common organisms, again, are usually staph organisms, which are skin organisms. When we look at ventricles, it's important to look at the baseline of the child. You don't want to just say, oh, their ventricles are big, because they may always be big. You can look at their scans when they have a known malfunction and see what they look like at that point. You can look at them at their baseline when you know they felt good and try to determine whether they're changed or not. And that when we're scanning them, whether it's a CT or an MRI, they're different modalities, so you really have to look in different angles to try and sort out whether their ventricles are larger. And depending on how the scanner is angled, it may change the look of the ventricles, so you may think that they're bigger or smaller, and it's important to really look at them carefully to determine that. Again, this is the lateral ventricle, third ventricle. This is the bottom part of the C of the lateral ventricle. This is the fourth ventricle, but you can see all those ventricles on this one scan, and it's because of how the gantry or how the scanner was angled. Again, this is just showing the ventricular system. And ventricular size is not necessarily an indication of increased intracranial pressure or shunt malfunction. You can have very small ventricles like this and be in shunt malfunction. You can have large ventricles like this and not have any shunt malfunction and possibly not even need a shunt. You may just have large ventricles called ventriculomegaly, but not hydrocephalus. And so that's why it's always important to look at the pictures, compare them to previous pictures of the child, and put it together with their symptoms and not just go by a picture. In this particular image, you can see that there is some pressure because there's capping of the ventricular system right there, and that's the transependymal fluid that can't get into the ventricular system, and this child has pressure. I'm going to see if this plays on here. I'm not sure with our system whether it will, but let me see. This is I just took this off the internet. It's a third ventriculostomy. I just wanted to show it to you to explain. So we're actually looking into the ventricular system. This is the third ventricle. That's choroid plexus. I don't know how to make it silent. Hold on just a minute here. Mute. This is the floor of the third ventricle right there. This physician is opening the floor of the third ventricle. They use a little laser fiber there. We don't use lasers. We use a blunt dissection there. And now he's just dissecting it bluntly. And in a minute you'll see when we open this where the fluid's going to go. But this is inside your ventricular system. So then you put a little balloon catheter in there once you have an opening in the floor of the third ventricle, and you blow up the balloon to stretch that opening, and that's what they're doing right there, blowing up the balloon to stretch that opening. Give it a minute there. And you're looking at this on a screen when you're doing this procedure. And you're working through a sheath that goes directly into the ventricular system that you're putting your instruments through. And in a minute you're going to see that there's a nice opening there. And the important thing to remember is there's the basilar artery. That's right, I'll show you right there. And these perforating arteries, this goes to the brainstem as well as these perforating arteries. It's a very important structure. But you see you have a nice opening here. And that's one way you can treat hydrocephalus. We're trying to do that more often to try to eliminate shunts if we can. Another thing you want to look for sometimes when you're looking at imaging is whether they have temporal horns. In general, you really shouldn't see fluid down in this area. This is the bottom part of the ventricle or the bottom part of the C of the lateral ventricle. And when you see that, you always have to think, oh, well, maybe they have pressure, and follow that through. Sometimes when you shunt children and they have overdrainage or are shunted a little too much, they may develop these subdural collections or some fluid around the brain. And that's why programmable shunts are useful sometimes, because you can turn up the valve, increase the pressure in the ventricular system a bit, and get rid of these subdural spaces. Ultrasounds are another way we look at neonatal brains. They're easy to do in children who have open fontanelles, and you can often see if the ventricles are enlarged, if there's any blood in the ventricle. So that's another imaging modality. If we're going to do a procedure, we like to get an MRI so that we can really look at structures and determine whether there's anything else going on that we need to know before we just do a procedure on the child. Post-operatively, when we change shunts, the important thing we want to look at is their mental status. We want to know if they're awake, alert, if they are talking to us and telling us they're feeling better. Even children who are delayed and can't really verbalize, their parents always know what their baseline is, and so we always talk to them about, do you feel that they're acting the way they normally act? You always want to check their vital signs, of course. You always want to make sure there's no fluid collecting around the wound where the shunt is. You want to make sure their abdomen's comfortable, they're in no pain. And you want to make sure they don't have any hematoma in their neck area, because when we put the shunt in, we do pass an instrument along the neck area to get down to the belly, and it's an area that's tender, so you want to make sure you don't have any hematoma in that region. As far as take wound care, the children can shampoo their hair the day after surgery. It's important to keep their hair clean and dry, and when they go home, they can wash their hair every day. Just keep it clean and dry, and look for any drainage from the wound or any redness. The most important thing, as I said, is mental status change. If children are having headache, but they're getting sleepy, they're sleeping more often than usual, they're not waking up easily, that's the most important sign that we see. Again, the treatment options are shunting, third ventriculostomy, where we open the floor of the third ventricle. In premature babies, we sometimes put in a reservoir to tap, because we want to see if we can let the blood clear up in their fluid pockets before we shunt them, or we want to determine whether they will need a shunt. Maybe they'll clear up the blood and go on without needing a shunt. The other thing we do more often is a subgaleal shunt, and what that is a shunt that goes into the fluid pocket in the babies and goes into the subcutaneous tissue of the head. So we create a pocket in the scalp, and that's where the spinal fluid drains to. We can leave them in for 3 or 4 weeks if they'll keep draining, and sometimes it allows the children to clear up their ventricular fluid so that they don't go on to need a shunt. Long-term picture, the children, if they have a shunt, will require lifelong care. If they have a third ventriculostomy done, they need to be followed for quite some time. Sometimes the third ventriculostomy can close. If they have any symptoms, headache, vomiting, any other symptoms of increased pressure, they need to call us immediately and not wait. But as time goes on, the children with third ventriculostomies may not need anything done and will have less follow-up. They get to know their neurosurgeon well. Most kids who have shunts will require a shunt revision, and maybe certainly more than one. There are children who tend to get more shunt revisions. It seems to be a smaller population. So if you have 1,000 children with shunts, there may be 200 that seem to be more repeaters of needing shunt revisions over the years. There are some children who can go 10, 15 years or longer and not need a shunt revision. But at some point, the tubing either gets brittle, it may break. We revise the distal tubing sometimes, so most children will need some revision. It can possibly shorten life, but again, I've known children who have lived a long life so far and have done very well and continue to do well. At major children's hospital, children die each year due to shunt malfunction, increased intracranial pressure, because they don't get to us in time. Sometimes, I worked out in Utah for a while, some kids lived 3-4 hours from any hospital, and if they were sick and couldn't get to medical care fast enough and get flown to us fast enough, sometimes they would not make it because of the distance. So whenever a child calls and they have a shunt and they have a headache or any symptom, even remotely leading us to think they might have a shunt malfunction, we bring them in right away and investigate it. The important thing we tell pediatricians and practitioners and parents is listen to your inner wisdom. Is your child sick? Is this a sick child? If it is, then act on it. Always listen to parents. They know their kids. They know when something's not right. And if they say there's something not right and you do something, you say, well, it doesn't look like it to us. The pictures look good or something. But they're saying, no, there's something wrong. It's important to keep the child, watch them, and investigate further, because the parents, in my experience over many, many years, are right 99% of the time. So I think that's really important. And increased intracranial pressure from hydrocephalus shunt malfunction is really a clinical diagnosis supported by imaging. So I think that's important to remember as well. Any questions? Yes.
Does third ventriculostomies, can those close up again over time?
Yes, yeah. Third ventriculostomies can close up. Most of them stay open, but it's important, that's why I said it's important if the children have any headache, any vomiting, any signs, even like a low persistent headache, they need to come back and get investigated because they can close up. Sometimes you can reopen the third ventriculostomy if it does close. But it's important that the families know that they don't say, oh, the third ventriculostomy is done, I don't need a shunt, I'm out of here. Because they can sometimes close up. And I have seen, again, it's probably because of where I had worked for a while, that we were a big center, but many kids lived far away. And if they couldn't get to us fast enough, I have seen kids get in trouble with that. So, and particularly in the little ones, like I said, the third ventriculostomy seemed to work better in an older population, in the little tiny infants. It's important to make sure that you follow them and make sure the third ventriculostomy is working well for them. And you can sometimes redo it. Sometimes they just need a shunt because they're not absorbing the fluid well. Sometimes we've looked and the hole is still there and it's open, but they're not absorbing their fluid. So sometimes it just doesn't work for that reason. Okay. All right. Thank you very much. I appreciate it.